Hello, my name is Richard Gardner. I'm a children's orthopedic surgeon based at the Hospital for Sick Children in Toronto. And it's really my pleasure and honor to be with you today. Huge thanks to the Harvard Global Orthopedics conference team for inviting me to do this talk. I'm really delighted to be doing this. Just to give some background, I'm currently working in Toronto, but I spent the last 10 years working in Ethiopia and Zimbabwe with the Cure International Children's Hospital network. And that's where the majority of the content of this talk is from regarding the patient cases. So thank you very much for your time. So my remit is talking about Blount's disease. And some of the objectives that I think would be helpful for us to go through today would be to differentiate physiological genu varium to that which is pathological. To understand how the management of Blount's disease differs according to patient age. It's a fascinating condition, and depending on the age of the patient and the severity, the surgical management is very different. And it's important that we make the right decisions for each patient who comes through based on age and severity. And then to determine when to use guided growth, when to use osteotomy, when we should be doing an acute correction and when maybe the gradual correction makes more sense. And then also some strategy in managing the severe case that I'm sure all of you have seen and have some experience of. So just from the outset, normal physiological angular positions of the knees, we start off as an infant standing in varus. As you can see, this is the Selenius curve, which is I'm sure familiar to you all. And we start off in varus. At around the age of 18 months, our bow legs become straight and overcorrected to some valgus, with a maximum valgus being between the age of 3 and 4. Before we go to the standard tibiofemoral angle of some 7 degrees of valgus by the age of 7. And this is important because a child who is, say, 1.5 years of age, with bow legs may well not have infantile Blount's. This could be part and parcel of standard physiological development. And so trying to select natural history from those with a pathological condition is important. Likewise, if you're seeing a child with knock knees with genu valgum at the age of 3, you may choose to wait for 2 years or 3 years before managing them, given that in the majority this will settle down. Now, in the more severe cases, that's not the case, but in the minor cases, that is often the case unless there's an underlying metabolic cause. So understanding the natural history is crucial. And then also just to make sure there's not an underlying diagnosis, which is very common. Rickets, of course, vitamin D dependent or vitamin D deficient rickets. It's remarkable how vitamin D deficient rickets, just the miraculous closure of or miraculous healing of the physis that can occur. So this child here, x-rays of both the knees and the wrist, in this case had genu valgum, but huge thickening around the physes. And then with appropriate treatment of vitamin D and calcium, just the extraordinary healing that happens. And so we'd always want to treat the rickets first, allow ideally 6 months to 12 months of recovery before deciding on any surgical treatment. The great advantage, of course, is the bone quality is that much better. And also in milder cases of angular deformity, these can resolve over the first 6 to 18 months following metabolic correction of the underlying deficiency. So just checking you're managing rickets before treatment is key. So infantile Blount's. So it's a developmental condition. It's a disorder of the posterior medial proximal tibial physis. So it's the medial aspect and the posterior medial aspect proximal tibial physis, where there's a relative growth inhibition. And over time in infantile Blount's, this will continue to progress in severe cases and can lead to eventual premature physeal arrest. Now, Blount described this nearly 100 years ago as tibia vari, but it is more complex than that. There's a varus malalignment, there's procurvatum of the tibia, there's often significant internal rotation of the tibia, internal tibial torsion, and there can also be distal femoral deformity, which in some cases is varus, in other cases, in the later cases, can even be valgus. So defining and trying to decide which one might be a physiological genu variant versus Blount's disease is important and can be problematic, especially in the infantile case. And just the enormous growth of the physis is so crucial, with 20 to 25 centimeters of growth occurring from the age of 5 around the knee. So if there's any physeal asymmetry, it can create a very, very severe angular deformity indeed. And that can be something that just with no underlying cause, and sometimes there can be an iatrogenic cause following surgery. So we do have to be very aware of this. I think it is very helpful not to just categorize this as infantile and adolescent. I think it's helpful to talk about infantile being onset of less than 3 years of age. Juvenile, when the onset appears between 4 and 10 years of age, and adolescent over the age of 11 years of age. I would say, though, that you do often, even in the juvenile cases, it seems like these cases have been present for some years before, but bringing them into these blocks, it does actually also help guide our treatment as well. So I hope these videos project, and these are 2 children with infantile Blounts. And the thing that I hope is clear with these children is in the stance phase, you see quite a significant lateral thrust. You can see the leg jolt to the knee jolting laterally during the stance phase. And I think that this is an important clinical finding, which we look at beyond just ligamentous laxity of the knee and measuring the degree of genu varium, but having a significant lateral thrust combined with suggestive radiographs, I think is very helpful for us to decide which children we should be planning to intervene on. So regarding the radiological classifications, there's the Drennen's metaphyseal-diaphyseal angle. And then the standard classification is the Langenskiol classification, but it's really more of a staging system rather than a classification. And it's a description of the evolution of infantile Blount's disease. So for the first Drennen's metaphyseal-diaphyseal angle, now Drennen's paper, he reported on 30 patients, of whom 29 of those 30 whereby they had a metaphyseal-diaphyseal angle greater than 11 degrees progressed. Their genu varium got worse. And measuring this angle, you can see on the third picture across to the center of your screen, it's a line running parallel with the tibial shaft. Then you subtend an angle perpendicular, so 90 degrees to that angle from the tibial shaft. And then you draw a line interconnecting the tibial metaphysis. And often in Blount, of course, you've got this medial metaphyseal beak. So it's easy to draw from the lateral proximal tibial metaphyseal corner to the medial side. And it's that angle between the perpendicular line off the tibial shaft to the metaphyseal, tibial metaphyseal line. Now, Blount said if this was over 11 degrees, the majority progressed. I think many of us will take an angle a little bit higher, maybe even 15 degrees. But it's very helpful to look at this. And I think this in combination with the lateral thrust is certainly very suggestive for likely progression. The Langenskiol staging system is very helpful. So this is really talking about the evolution, the condition of infantile Blount's, and really it goes down with the age of the patient. So stage 1 to stage 6. The stage 1, you can see the picture on the top left, you've got some medial metaphyseal beaking, and that's often between a child age between 2 and 3 years of age. The stage 2, a child's a little bit older, between 3 and 4 years of age, where you start to see the saucer-shaped defects in the metaphyseal region of the medial proximal tibia. Stage 3, this saucer is no longer quite such a shallow saucer. It's more like a step. It's more of a right angle defect in that medial tibial metaphysis. And often you see this later at the age of 4 till 6 years of age. And then stage 4, the epiphysis starts to bend down over. Now, sometimes you don't see the epiphysis bending down over the proximal tibial metaphysis. Sometimes you just see a defect because often that epiphysis hasn't ossified yet, but you would see that with an MRI scan. And then stage 5, you get this appearance of this double epiphysis, where you've got severe sloping into the metaphysis, often with a physeal line above it. But that's really representing that posterior medial depression. So you're seeing the physeal line from the anterior aspect of the tibia, but then this double physeal line is because you're seeing the physis posteriorly as well, superimposed on that proximal tibial metaphysis. And then stage 6 is when you develop a medial bony metaphyseal bar. And you often don't see this radiologically until the age around 10, 11, 12 years of age. So I hope that's helpful to see, just working through this as being always an evolution of the disease. And of course, different treatments are required for different levels. And we'll try to bring some flavor to this through the following pictures. So what are our treatment options? So non-operative, of course, we can monitor growth. If we've got any doubt to say this may not be severe, may not be Blount's, it may be physiological, monitoring growth would, of course, be the right thing. And just to see if there is any progression. Bracing is used, and there are some papers out there who do support bracing. I don't personally have any experience of that, and I haven't found it to be useful in my experience, but there's a paper here from Sanjeev Sabharwal talking about which highlighting bracing, and it's certainly an option. But the major surgical indications or the major surgical treatment options would be physeal surgery, whereby we'd be doing a hemi-epiphysiodesis, so putting an 8-plate or a staple to slow growth on the lateral aspect to allow the medial side to catch up. An acute corrective osteotomy or osteotomies, whether you do gradual correction using a frame or whether it's a combination of all of these. And then what are the other decisions? Well, if you are going to do an osteotomy, what incision are you going to use? Sometimes you have significant distal femoral deformity, and when is it bad enough to merit a combined distal femoral correction as well? At what age should we consider doing a hemi-plateau elevation when you've got severe sloping in the medial proximal tibial physis? And what is the role of 8 plates? And then again, what are the strategies in the severe case as well? So here's a child here. Child is 2.5 years of age, significant genivarum, walks with a lateral thrust. You can see there's some flaring of the distal medial femoral physis and the proximal tibial physis on the medial aspect. We know through the Hoyter-Volkmann principle that pressure across a physis will slow the physis, tension across a physis will speed it up. We often see in these children stress. So this is rickets, this is stress across the physis that we're seeing here. You look at Drennen's metaphyseal diaphyseal angle, and the angle here is 20 degrees. So certainly this would suggest further progression. The mechanical axis, of course, is a long way medial than we would want. And this is probably staging between a 2, more likely a 3, where you can get this sense of a step in that proximal medial tibial metaphysis. So we've got a stage 3, Langenskild. Drennen's angle is 20 degrees. And you can see we've got distal femoral and proximal tibial deformity here. So should we just correct the proximal tibia, leave the distal femur? You know, I think this is people take different paths on this. I tend to, if there's a very oblique joint line, do a correction of both. And if the joint line is parallel to the ground, I'll tend to just work with the tibial deformity. And I'll show you an example of this in this case. I felt that there was significant obliquity of the joint line. And so this had a combined osteotomy with a proximal tibial osteotomy. You can do different forms. I think it's helpful to base your incision just lateral to the tibial crest, just in case you had any wound issues, so you're not, directly looking at bone. I tend to cut through the periosteum carefully and then elevate around just at the level of the osteotomy. I tend to just do a lateral base closing wedge, and I keep it a transverse cut, so parallel, so perpendicular to the proximal tibial metaphysis, perpendicular to the diaphysis, to allow rotation. So you can dial out the internal external rotation. There are certainly other osteotomies like the RAB osteotomy, which is more oblique, and that allows you to correct the angular deformity and the rotation in one. But I find a transverse osteotomy taking out a lateral triangle to be very effective to enable you to correct, get slight overcorrection of the various deformity as well as correcting the rotation. And the child will then go into long leg casts. At the end of this osteotomy, I think it is important to close the periosteum so that you've got a good periosteal closure over the top of the bone, and then doing a subcutaneous anterior compartment fasciotomy. So you're just sliding your scissors down under the skin over, opening up the fascia of tibialis anterior. So you're just sliding your long McIndoe scissors directly down under the skin, all the way down along the anterior fascia, just to open up the anterior compartment. It is important for these cases as well. So in this one, this had, in addition to the proximal tibial osteotomy, also had a distal femoral osteotomy with satisfactory correction. But in other cases where the joint line is parallel to the ground, I think it is reasonable just to do the proximal tibial correction. Again, this is a different child with significant genu varum, with a Drenan's angle of some 20 degrees, also having significant distal femoral deformity. And really, I'm talking here about the 2-3-year-olds. So the very young children, whereby I think it's reasonable not to do a distal femoral correction at the time. So slight overcorrection through the proximal tibial osteotomy that I tend to stabilize with 2 cross pins. Those pins then come out between 4 and 6 weeks. And then depending on the healing, whether or not they need another week or 2 of a splint or the cast can come off. But you can see in this case, the distal femoral deformity very rapidly improves to near a normal mechanical axis, and your distal femoral correction resolved very nicely. So I think in these situations, just addressing the proximal tibia in the young 2-3-year-old child who is likely to progress is a reasonable strategy. So older children. So in a 4.5-year-old female, what are we going to do here? So now we've got a more severe situation. This is still infantile Blount. We're moving towards more of a juvenile type. This hasn't been treated. And here you can see there's some lateral subluxation of the tibia and a very foreshortened medial epiphysis and a large medial metaphyseal spike. Now, this is more of a Langenskild stage 4. Now, if we were to leave this be with just a tibial osteotomy, the chance of recurrence is very, very high. So in these cases, I would recommend we proceed with both an osteotomy and add in guided growth. So osteotomy to correct a slight overcorrection of the tibiofemoral axis, secure with cross pins, or if you wish, a plate, and then to put a proximal lateral tibial plate, 8 plate, or you can use a 2-hole tubular plate, or you can use a staple, just to tether growth of lateral proximal tibia, which is so important because, of course, with the Hoyte-Volkmann principle, this proximal tibia, medial tibia physis has been squeezed, and it's a sick physis, and it's going to take time to recover. And if you just do the osteotomy alone, this will bounce back into Varus very, very quickly because that physis has not had a chance to recover. And the A plate affords it that time. And then you can see over the course of the next 6-9 months, maybe a year, the A plate starts to widen because that medial physis the physis is starting to grow, but you can start to see how the medial aspect of the physis is starting to recover. You're starting to see a medial proximal tibial epiphysis. And if you look a little bit more closely on this, you can see the growth for Harris line, which is coming right the way across, suggesting that medial physis is actually growing. We've left it to slight overcorrection, knowing that there will often be some bounce back after removal of the A plate. So at this time, you take the A plate out and then watch closely. Now, follow-up is so important because if in a year that slight valgus starts to drift into slight varus, you need to put that A plate back in again. So you do need to watch these children closely. But I think an A plate from the outset is important in such cases. A 5-year-old male, similar, possibly worse, but a similar looking radiograph treated exactly the same way. Nice, slight overcorrection. A plates look to be working well. In this overcorrected position, A plates have been removed. But if you just look at this side here, we're a little bit more skeptical about the longer term recovery for this child, because you can see the Harris line looks to stop. Now, whether or not this will be indicative of an earlier recurrence, I think there's more of a chance in this one. And so this is a child you'd want to see again after 3 months and then 6 months and certainly a year, just to see if this is starting to bounce back into varus. And if that's the case, get in there early by putting that 8-plate back in. So the more severe cases, the 5s and the 6s. So these, of course, are older children. Now, Teddy Hoffman is a giant of children's orthopedics and led the service at the Red Cross Hospital in Cape Town for a generation. And he wrote a very important paper here looking at 34 knees and 24 children, and found that for those children over the age of 8, when he did a hemi-plateau elevation, because there was such severe depression of that proximal medial tibial epiphysis and metaphysis, if he didn't do a lateral proximal tibial hemiepiphysiodesis, the recurrence rate was guaranteed. And he's really taught us that certainly from the age of 9 and over, we do need to drill out the proximal lateral tibial epiphysis, the proximal lateral tibial physis, which feels early, but without doing that, or at the very least putting an 8-plate or some guided growth over it, recurrence, and very rapid recurrence, is guaranteed. So how do you do the hemi-plateau elevation? I am a big fan of a 2-incision approach. It was taught to me by Jim Harrison, who worked for many years at the hospital in Malawi, and I think it's a really elegant way of dealing with this. So the first incision is a short incision on the medial border of the proximal tibia. And the reason why that's so important is because if you did a hockey stick incision, starting from the anterior aspect of the proximal tibia, sloping backwards, which would be more of a standard incision, the problem is that your osteotome needs to be on the very posterior border of that medial tibia. And you get that osteotome in, it means you're really stretching that skin right the way around, and having skin complications, wound issues for a single incision is very, very common indeed. Instead, placing a short incision over the posteromedial border of the tibia, where you move the hamstring, of course, you've got the pes anserinus coming here, you move the hamstring tendons out the way, and you can get to that medial metaphyseal peak very, very easily to your hemi-plateau elevation. You make sure you've got some good protection around the back, and you put a Krago retractor or something around the back to protect the neovascular bundle, and you have really excellent access to do that hemi-plateau elevation. And then to do your second osteotomy, which of course is your proximal tibial osteotomy, you do that just lateral to the tibial crest. And so you've got a big, wide skin bridge. I haven't had issues with the wounds with this. The skin bridge is very broad, and it's a very safe way of addressing both in a much more direct way than just doing a very long hockey stick, which is prone to the wound issues. And here you can see, so this is the approach for a hemi-plateau elevation. This is the medial aspect of the right knee. You can see the osteotome is just under that medial metaphyseal beak. The instrument on the right is a Krago retractor, which is passed around the back of the tibia. And then you can see there's a C-arm there, and we're very carefully elevating that medial proximal tibial plateau. And you can see here's some x-rays. This is a relatively mild case. The osteotome on the top left here is coming into this metaphyseal beak, and you can see it's gradually passed up, aiming for the lateral tibial spine. I think is a really good landmark. You're coming across here. We've given up on this physis. You can see this child before, it had an 8-plate, it's broken. There's a growth arrest here across the medial proximal tibia. And so this 8-plate was removed later on in the operation, but we passed the osteotome up to that tibial spine. And then that is then gradually elevated and hinged so that you can get the joint line level. And then you can take either some fibular graft. Increasingly, I've come to use iliac crest. I really like iliac crest. I've tried cortical iliac crest. I think it gives a great interference fit. I'm using it more now than I have been doing fibular graft. The fibular graft works just as well. And then doing your proximal tibial correction through the second incision, just lateral to the crest. And then you can get a very nice elevation of the proximal medial plateau. And then you can slightly overcorrect by your laterally based closing wedge and any rotation needed. The really important part, of course, is then scraping out the physis of the proximal lateral tibia. Crucial to avoid early recurrence. Children under the age of 10, I would also drill out the proximal tibial physis as well. Can be through the same incision. Come at it anteriorly. Make sure you're not popping out the back. Do it very carefully under C-arm, just to avoid any injury to the coronary nerve. And it gives a very reliable outcome. So that would be the approach for hemi-plateau elevation. Works very well for the milder case as well as for the severe. And here's a severe example of a child where that proximal tibia, proximally that medial joint line is parallel with the tibial shaft, even worse than the tibial shaft. Now, this doesn't work quite so well for a frame in my hands because the frame would almost be parallel with the tibia, and getting that frame in without at least doing some correction is not possible. So it is possible to do these severe cases all in one go, but doing a partial correction during the rest of the frame, I think, is also a very elegant solution. It can also give you some opportunity for lengthening as well. But using the same approach, hemi-plateau elevation, again stabilizing this time with a fibular graft and a high tibial osteotomy. I'm tending to use more little T-plates now to stabilize this. You can see there was a lot of distal femoral valgus, and this was corrected with a blade plate. And so even the severe deformities, you can correct them quite nicely and bring the joint line level using this technique. Just to highlight recurrence. So a child here, you can see she's walking here with a significant lateral thrust. And this was a child who 2 years before was treated, I think probably had a Langenskill 3, maybe 4 level in her progression of infantile Blounts, but no 8-plate had been put on. So it was just overcorrection, very nice x-ray showing overcorrection using a proximal tibial osteotomy. But this recurred very rapidly within 6 to 9 months because no 8-plate had been put on that proximal lateral tibial physis. The disease then progresses, and 2 years on has got severe joint deformity here, a stage 5 Langenskill needing a combined hemi-plateau elevation, proximal tibial osteotomy, as well as drilling out of the proximal lateral tibial physis. So again, 2-incision approach, this time using ionopressed bone graft, scraping out the proximal lateral tibia, using a little T-plate for stabilizing of the proximal tibial osteotomy through that second incision, and then a pretty decent correction of that joint line with normal valgus alignment of the knee. Important here, you can see that the physis here is now closed down. And so hopefully recurrence won't be occurring in this case. With all of these cases, it's very reasonable to also do them with a frame. And if it's a unilateral condition, also lengthening at the same time, I think is very elegant indeed. So adolescent Blount, it generally occurs later, after the age of 11, 12 years of age. And there's no or really minimal medial joint line depression. It's predominantly a proximal medial tibial vera. It's often in much heavier children as well, and sometimes gradual correction can be helpful in this case. So taking this young man here, he's 15 years old, he weighs 95 kilograms, he's got mild varus through the distal femur, he's got significant varus through the medial proximal tibia, and I think the correction of both of these cases would be very elegant. In his situation, we had to do it all through the tibia, which I think is less than ideal, but his family circumstances didn't allow a second large operation. So he went through guided growth sorry, not guided growth. Sorry, he went through gradual correction using a frame. So we used a tailored spatial frame to gradually correct this, but any conventional hexapod frame works very, very nicely, and you could use this with a monolateral as well. The gradual correction here through the proximal tibia. Now there is the way that you can also do this as well, using the fulcrum being the proximal tibia fibula joint as well, to avoid needing to do a fibular osteotomy. Gradual correction there with healing and a satisfactory outcome at the end. So using a frame for heavier children can be a very beneficial way of dealing with these to avoid metalwork failure. Sometimes the adolescent Blounts can be much more severe. Again, minimal in the way of joint line deformity, but you can see here has deformity at the proximal tibial metaphyseal region. So your normal medial proximal tibial angle is 87 degrees, subtended to the tibial shaft, gives around a 76-degree deformity here. Now, you could do this with a frame, doing a partial correction and then swinging the rest around with a frame. It's also possible to do this acutely and doing it safely. You do need to resect a good trapezoidal area of bone, though. And I think a good technique, which was recommended to me by Scott Nelson, who's really got a tremendous experience in this area, was to do a very proximal fibular osteotomy. Because if you do your fibular osteotomy in our classic way of mid-shaft, you end up, it often blocks the correction and it can dive itself into the posterior muscular compartments in a very unhappy way. So doing a very high fibular osteotomy is helpful. And you can do the tibial osteotomy through the same oblique incision, continue down to the proximal medial tibia. So you can see here, this is over the lateral aspect of the knee. Here's the fibular head around here. Here is the common peroneal nerve as it dives down into the anterior compartment. So do a full release of the common peroneal nerve and its branches is coming down. And then you can do a fibular osteotomy. You've protected it, do a proximal fibular osteotomy here. And then extend the skin incision to allow you then to access the proximal tibia, where you can remove that trapezoidal wedge, and then stabilizing with a frame or with a plate. Again, being very careful to make sure you do an anterior compartment fasciotomy as well through under the skin. So I think I've come to the end, and I'm really grateful for your time. I hope that you've stayed with me through this, and this is all made good sense. I'm sorry, it's not interactive for questions, but it was just to really finish up by saying we just need to recognize the different ages of presentation and the varied treatments. But for those under the age of 4 years of age, a proximal tibial osteotomy is often sufficient. When the child is severe and between 4 to 5 and certainly 5 to 8 years of age, you need to combine your PTO with guided growth using your 8-plate or staple. Over the age of 9 years, when you've got a severe hemi-plateau depression and you're doing a hemi-plateau elevation, you pass that chisel across the physis, that medial physis is shut down anyway, and you do need to drill out the proximal lateral tibia. Lady Hoffman showed us that very clearly. And then for the adolescent cases, typically don't have joint line deformity, a proximal tibial osteotomy is often sufficient, whether that be the frame or you do that acutely. A huge need for a close follow-up. Anyway, thank you very much for your time. I didn't write my email here, but it's richard.gardner, Gardner, @stickkids.ca. And you'd be really welcome to send me any questions. I'll be delighted to get back to you. Thank you very much indeed.